Good morning for another 4 minutes. Good morning. I'm Catherine Kuhn, Vice President of Government and Community Relations here at the Medical College of Wisconsin, and I want to welcome you all for being here. I'm assuming you all are very interested in Medicaid and that you didn't win the lottery and you don't have tickets to opening day. So with all of the rest of us, we will persevere without that lottery money. But anyway, thank you so much for coming to listen to some thoughts about Medicaid expansion. And I just want to say that we're very excited to hear from our speakers today. And with that, I would like to just turn it over to Jeff Mayer. Thanks.
Thanks a lot, Kathy. And thank you to MCW Medical College of Wisconsin and Abby Stein, especially for helping set up this briefing on Medicaid expansion. Before we get started, there's lunch out there if you haven't already grabbed it. Also, this is our printed directory from wispolitics.com. Has all the photos of state representatives, state senators, and members of the Evers cabinet. So please pick up one of those. Also want to thank our sponsors for this and our Milwaukee event series. UW Milwaukee, Medical College of Wisconsin, 1125 at PAPS, Spectrum, the Firm Consulting, and the Milwaukee Police Association. So thanks very much to our sponsors. And you can find out more about all the WisPolitics event at wispolitics.com. So why are we doing something on Medicaid expansion? Well, we cover politics, but we also cover the budget and big issues before state government. And one of the pivot points in this budget debate, which is unfolding in Madison, is Medicaid expansion. Governor Evers has proposed taking the federal Medicaid money, and Republicans in the legislature say no. But there may be it may be a point of compromise at some point. And so we want to lay the groundwork on this complicated issue. So to give the administration's point of view, we have Jim Jones. He's the state Medicaid director. He's a veteran of the Department of Health here in Wisconsin. Before coming back to DHS, he was a consultant at Deloitte. And so now he's the state Medicaid director. So please welcome Jim Jones.
Hi, everybody. How are you guys doing today? You guys are missing the opening day just like I am right now. I really thank you and thank everyone for inviting me here to talk about Medicaid expansion in Wisconsin. I am really excited, again, mostly about opening day, I have to tell you, but also to talk to you about what the governor's plan for Medicaid over in his proposed budget. As I mentioned, perhaps was mentioned, I've been here a month. I started about a month and a day ago. As the Medicaid director. Prior to that, I had spent 31 years at the department. I started as a very low clerk and worked my way up until I was the deputy Medicaid director under a guy named Jason Helgerson, and I did that for 4 years. And then for 8 years, I moved into consulting, stayed in Madison, and every Sunday or Monday I got on a plane and I traveled around the country and I consulted with states and the federal government and with health plans and not-for-profits on Medicaid every single day. And so as I did that, I worked with lots of different people. I worked with red states and blue states. I worked in Oklahoma, I worked in Texas, worked in Pennsylvania when it was a red state. I also worked in New York and California and a bunch of other states in between. So as I did that, I saw a lot of different models. I saw a lot of different opportunities that states were taking advantage of. Some of these were expansion states, some of them were not. But honestly, I've never seen a greater opportunity when it comes to Medicaid than Wisconsin has right now with the expansion of Medicaid and the ability to draw down more money. So, the Medicaid expansion that we're talking about is really a lever that allows us to infuse new federal dollars into the healthcare economy in Wisconsin and really impacts all Wisconsinites, not just those on Medicaid, and not just those who are part of the expansion. Expanding Medicaid to the federal threshold, which is 138% of poverty, really allows the state to claim 90% federal match. Currently, we're able to basically draw down about 60% federal match. So it's about 30 cents on the dollar more than we're drawing down today. And that is just by making that jump from 100% to 138%. And it's covering not just, many times you'll hear childless adults. It's childless adults and its parents of young children. This will actually result in two different outcomes. Number one, we immediately, with expansion, save the state $324.5 million in state money. At the same time, we're able to draw down $1 billion more in federal funding. And you may ask yourself, how does that actually happen? It happens because we can claim the higher match for all the people between 0 and 100% that we're already covering. So we get that additional federal match, and we get the match for those people between 100 and 138% of poverty. Then we take all of that money, and the governor's budget reinvests all of that money back into the healthcare system through new initiatives to expand access, to strengthen our healthcare workforce, and expand coverage for vital services. That means that we can actually draw down even more federal money, another $573 million, as we expand the program and we provide more money to our workforce and to our providers. This results in a total of $1.6 billion in federal funding we do not have today that would be used to make a historic investment into Wisconsin's healthcare system. The governor's budget not only increases coverage, but improves access and quality by, it addresses provider reimbursements, it tackles workforce shortages, and it expands benefits for additional services, bringing us into the 21st century in many cases. Overall, in the proposed budget, we invest an additional $367 million in hospitals, $48 million in increasing access to dental services, $69 million to increase payments to physicians and other behavioral health professionals, including psychiatrists. It supports our direct care workforce by increasing the reimbursement for personal care across the board in long-term care programs and in services, in nursing facilities, and in personal care, so that we're paying those workers a competitive wage. And the budget will increase the number of dementia care specialists from 21 to 48, so that we have a dementia care specialist in every aging and disability resource center in the state. Now we talk about a little bit about reinvesting in the system and providing better coverage, more reimbursement to our providers, strengthening the workforce, but want to expand. If we really want to help working families in Wisconsin, and this is the group of people we're talking about, are working families and working individuals, we need to expand Medicaid up to that federal threshold. The Medicaid expansion has shown in other states significant growth, and it supports employment. Other studies conducted in Michigan and Ohio find that Medicaid makes it easier for beneficiaries to maintain employment. The expansion also helps us to smooth that coverage cliff that exists for people with incomes that fluctuate or are at or near the poverty level. These are minimum wage workers who make about $7.25 an hour and face difficult decisions when it comes to whether I should work more hours, whether I should take overtime, whether I should take that promotion. Because if I do, I'll lose my Medicaid coverage. The people that we're talking about covering here are people like personal care workers, the people who take care of our grandmothers and our grandfathers, our moms and our dads every day, and are hovering around the poverty line and are worried about their health coverage, which they normally do not get covered by their employers. It also includes child care workers who are taking care of young children. And then finally, it also helps a lot of individuals who are nearing disability, who basically have disabling conditions that are slowly moving them towards receiving Social Security disability, or SSI in the state, and those who have actually fallen through the cracks of the disability system. It also, as we expand Medicaid, it improves affordability and financial security among our low-income populations. The Oregon Health Insurance Experiment, which included a randomized control trial designed to study the effects of expanding public health insurance coverage on healthcare use and outcomes, found that Medicaid virtually eliminated out-of-pocket catastrophic medical costs and reduced the likelihood of enrollees having to borrow money or leave other bills unpaid to cover medical expenses. We have people today who have to make a decision between paying for the rent, paying for their food, or paying for their medicine. We want to eliminate that particular problem that people are facing in the state of Wisconsin. Governor Evers and the majority of Wisconsin residents support expansion because they've seen how it can transform care in the 37 other states that have already adopted the expansion reform. In those states, Medicaid expansion is shown to result in significant reductions in mortality, improved self-reported health, and increased access and use of primary care and life-saving services. Beneficiaries are using coverage to obtain cancer screenings and other preventive services, care for chronic conditions, essential medications, and treatment for behavioral health conditions, including treatment for opioid use disorder. Our goal is to make sure that the right supports are in place at the right time for Wisconsin citizens. That's why the cornerstone of the budget is Medicaid expansion. Under the expansion, new enrollees will be connected to a primary care provider and maybe for the first time have a doctor to go to that is not in the ER. Having access to a regular primary care doctor may also increase use of preventive care and prevent emergency room visits in the future. So in conclusion, Medicaid expansion allows Wisconsin to cover 82,000 more adults. About half of those, honestly, are receiving their care through an FFM, usually through high deductible plans, usually with out-of-pocket expenses they can't afford. We can save $324.5 million in doing that in state money. And we can bring hundreds of millions of dollars of the federal tax dollars that we send to Washington, D.C. back into our state to reinvest in our healthcare system. And it's really not just the 82,000 childless adults we're talking about, it's all of those other groups that are mentioned in the budget. This is not just an investment in covering those 82,000 people. This is about covering people who are elderly, people who have disabilities, people who are developmentally disabled. It's meant to really focus on improving our workforce in the healthcare field, especially in the personal care, nursing facilities, and direct care workforce. It's meant to expand dental coverage. It is also meant to focus on behavioral health issues, including the opioid use disorder, but also across the board behavioral health. It's also something we can do to expand the kind of services that we actually cover. Right now, we cover some telehealth. We want to really look at that telehealth market, really look at those telehealth services to see what we can do with it and see if we can improve the health of people in Wisconsin, particularly those in the rural communities who many times do not have an opportunity or have to travel hundreds of miles to see a specialist or see a healthcare professional if they need. We want to use telehealth in that particular manner. Additionally, I think we want to focus on improving oral health access in the state of Wisconsin. We've proposed to add dental therapists as a particular classification, kind of like a physician's assistants for dentists, who can provide basic care for people. We've talked about expanding the amount that we pay to those dentists and those facilities that see more Medicaid and uninsured members when it comes to dentistry, and providing them with a rate increase across the entire state. Expanding our Seal a Smile program, and also supporting public health's oral health program. As we look at all of these different programs that we're reinvesting in, taking back that federal money that we've sent to Washington, D.C., creating savings in our own state budget, we want to make sure that everybody understands that all of that money that's saved, all the money that's pulled in, our plan is to reinvest it in healthcare. So for those reasons, the governor, Secretary-designate Palm, and myself are committed to evidence-based, fiscally responsible policies that will improve the health and well-being of the people of Wisconsin, and that's why we support Medicaid expansion. I have time to answer questions.
Okay, so let me just ask the first question, and then we can go in the audience and take a couple more. So yesterday there was a federal judge that ruled the work requirements in 2 states were for Medicaid were illegal, and so he blocked those. And Wisconsin's one of the states where Wisconsin was one of the states where the work requirements were approved. So what's the status of these work requirements?
Number one, I want to point out that We wait until CMS tells us what the impact on our waiver will be. The state law is still the state law. Act 370 is still there that requires us to implement that waiver. We are going to follow that state law to the letter. And right now we're waiting for more guidance from CMS as it relates to our waiver. We think that there's a long road down that they're going to go through. The other thing I want to point out is that our work requirements are a little different than Arkansas's and different from those in Kentucky, and that we aren't really quite sure which portions of the work requirements that are being done in those states might prove to be problematic. Then they may not be part of our particular waiver.
Okay, questions? Raise your hand and I can come to you. Yeah, Jim, just hold on a minute.
So what's the contingency plan as it parallels to the Affordable Care Act and, you know, the legal battle around that? It's being challenged. If the Affordable Care Act ends up being revoked, is there a contingency plan at the state level to address that once the Medicaid expansion is accepted and approved?
I think we have a long way to go when it comes to the Affordable Care Act's legality. We aren't at this particular point looking for a contingency plan. The Affordable Care Act remains the federal law that's in place. It's the one we're going to follow. It's the one we're required to follow based upon our agreement with the federal government with the Centers for Medicare and Medicaid Services. So as changes happen, we will respond to them. We will be proactive when we can, but we have to wait to let the legal system work its way through and see where we all end up.
Over here, Jim. All right.
Hi there, Ali Mari, take care. Specifically as it relates to LTSS expansion and some HCBS expansions, is there any initiatives under 1115 or 1915 waivers that state has or will be having specifically to enable aging in place?
Wisconsin has one of the things I've learned over the last 8 years as I've traveled the country is how great we have, what a great program we have in Wisconsin to care for individuals in the community. We're one of the first states, and I will argue with Minnesota, I think we were the first state to actually come up with the idea of home and community-based services. We are committed to that idea. We remain committed to it. We think family care and partnership and IRIS are awesome ideas, and they're ideas that we're going to continue to pursue. One of the sections of the budget, one of the provisions in the governor's proposal is to eliminate the waiting list for the Children's Long-Term Support Waiver. That is a program that right now is not an entitlement if there are not enough resources in a particular community, not enough slots in the parlance of the program. In that particular instance, those kids don't get served. The provision actually says we'll get rid of the waiting list, this will be an entitlement, and children who need these kinds of long-term supports will get them, and they'll get them in the community. You know, we're committed to the idea of a continuum for long-term care and allowing people not just to age in place, but to actually pick the right setting for themselves. Be that at home, in an independent living facility, in residential care apartment complexes, in assisted living facilities, or even in some instances in nursing facilities, if that's the best place for them and where they decide they want to be.
Hi, I'm Barbara Beckert with Disability Rights Wisconsin. So just to follow up, it's great news about the funding in the budget for the Children's Long-Term Support Waiver here in Milwaukee County. In spite of the good investment that Governor Walker made, we continue to have a waiting list. So I just wanted to see if you could clarify, because we've had some concern that the language does not indicate some sufficient, and if it actually is to end the waiting list and moving forward, and to not have a waiting list, just as we don't have one for adults. And in addition, if you could speak about the other investments for navigators and benefit specialists for kids where there's such a great need. Thank you.
Okay. So on the waiting list, it does eliminate, the funding that we're putting in eliminates the waiting list, and it moves it into a status where we will not have waiting lists in the future. That's the plan, no waiting lists. As it relates to navigators, there's money in the budget for the Office of the Commissioner of Insurance to have 5 navigators to help people with health literacy, et cetera. We remain committed to working with organizations such as yourselves and others to fund you to provide navigators, certified application assisters, any individuals who will help people understand the healthcare system, navigate the healthcare system, and end up in the right place, getting the right care so they can have the best health outcomes possible.
Okay,
Okay, for kids, we can talk more about that, Barbara.
okay, so we have
I think we have a meeting.
2 more questions.
Hi, I'm Sharon Young. I was curious, and I'm not sure how rampant it is a problem here, but I know that there's providers across the U.S. who don't take Medicaid funds and reject that. I'm wondering how much that is a problem in Wisconsin and how much this adjustment to compensation for providers might you expect would alleviate that.
It does depend upon the provider we're talking about. When it comes to hospitals, for instance, we included a fair amount of additional money to take us as close to the Medicare payment limit that we can possibly go. That said, Medicare or Medicaid do not pay what commercial insurance does many times. We've also added money for reimbursement for physicians and others, for nursing facilities, for long-term care, to make us as competitive as we can possibly be in the marketplace. Medicaid is a program. It's the program of last resort. And we pay as much as we possibly can in an amount that we think is appropriate to get the care for our members that we need. That said, are there instances in the state where we need to work harder on access, and particular services we need to work harder on access? The answer to that question is yes, and we're committed to doing so.
Hi, Milwaukee County Supervisor Supreme Mora Mukunde. I wanted you to speak directly to Medicaid expansion in reference to childbirthing assistance, specifically to doulas, midwives,
Yeah.
et cetera, and how those who would seek those assistances could receive them with the expansion of Medicaid through their health insurance.
Absolutely. One of the provisions in the governor's budget, and I didn't go through all of them because it would take us about 2.5, 3 hours, is doulas. We're basically adding doulas as a service for Medicaid members who are giving birth. We know that peer-assisted community support is essential. We know that it's really important when it comes to erasing some of the health disparities that we see in the state of Wisconsin, and we want to move forward with that. We also want to move entirely in that direction of looking at the reasons for the health disparities we see in communities around Wisconsin and try and find a way to alleviate them. Finally, we are also adding and changing the way that we provide care to women after they give birth. Right now, the law says that we cover them for basically 2 months after they give birth. The governor is proposing in his budget to cover them for a whole year. And based on medical research and evidence, that appears to be a best practice around the country.
Okay, Jim, I know you have another appointment to make.
I do.
It's not at the ballpark, though, right? Okay, because that would be cheating. Anyway, I want to thank Jim Jones, the State Medicaid Director. Please thank him with your applause.
Thank you very much. Thanks a lot. Thanks.
I appreciate it.
All right, bye-bye.
Okay, now we're going to move to our legislative panel. We have 2 members of the Assembly Health Committee, the chair, Joe Sanfelippo. Joe, please take your seat here. And we also have Representative Riemer, Democrat of Milwaukee. So please welcome Representative Riemer and Representative Sanfelippo. All right, make sure your microphones work. I think they're working okay?
I think we're good.
You okay now? Okay. All right, so, the governor proposes a budget, it goes to the legislature. So the saying is the governor proposes and the legislature disposes. So now the debate is on about what happens with the state budget. These are 2 members of the Assembly Health Committee, and Representative Sanfelippo is the Health Committee chair. And he's very prepared to represent what the Assembly Republican point of view is. Republicans control the Assembly and the Senate. So Representative Sanfelippo, you heard Medicaid Director Jim Jones. Why don't you lay out what the Assembly Republican response to the Medicaid expansion proposal in the governor's budget, please? And thanks for being here.
Thank you very much, and thanks for the invitation to participate today. I think that where the concern really comes in is the fact that in the proposal, what we're actually doing is we're taking anywhere from from 75 to 80,000, depending upon who you speak to, individuals, and putting them onto government-run healthcare program, right? Now, about half of those individuals already have insurance in the marketplace. They're in the exchanges. So you're going to be taking people out of private insurance, putting them onto a government-run program, and I think that's really where the disconnect comes in. I think there's a lot of shared goals between the administration and the Republican caucus on what we would like to do to be able to make improvements to the Medicaid program. But by adding that many people on all at once, I think we're really kind of setting the program up right now for failure and to have some at least very big stress points. And I will say that just basically with access, right? One of the critical things we hear, and we know for a fact right now, is there's an access issue with people who need to get in to see a doctor, whether it's a dentist or a physician, a general practitioner, or a specialist. And so when you start putting more and more people into a program that is already struggling to be able to serve the individuals that are there, I think that's a cause for concern. And again, the greatest difference I think we have is that the Republican caucus is not interested in putting people on a government program. Now, getting coverage is a very important goal that we all share. But again, when you look at the population we're talking about, there's only about 35 to 40,000 people that are identified as with no insurance right now. So why do we need to take people who already have insurance, take them out of their insurance programs that are their choice? They get to control what happens in those programs and put them into the Medicaid program. We just heard the Medicaid director say a few minutes ago, Medicaid was meant to be the last option of choice. That came from the Medicaid director. Yet, their proposal takes 40,000 people out of the private sector insurance, puts them onto a government-run program.
Okay, before we move to you, Representative Riemer, let me just ask, it seems like, I think one of the criticisms over time with Republicans and Governor Walker not accepting this expansion money was, well, there's free money there from the feds. We don't get enough return on our federal tax dollars. What's wrong with taking this free money, so to speak?
Well, again, nothing is ever free, right? Especially when it comes from the federal government, because it comes with all sorts of strings attached. But the primary concern is that going forward, is the federal government going to be able to keep up with their end of the bargain? Right now, we know for a fact that through the Affordable Care Act already, they have already reneged on several payments that go to providers, right? For the ones that have the high users and the different types of payments. We have also seen in the past, and we know for a fact, that the government throughout the years has gone back on their share of Medicaid reimbursements. They'll come back from time to time and take money away. In fact, we're seeing that right now in the CHIP program, which is why we have to add more funding into the CHIP program, because the federal government is reducing their share. So the last thing we want to do is build the entire state budget onto a program that we really don't know going forward those funds are going to be there, and they're going to be sustained at the current level that they are. It would kind of be like me preparing my entire family budget based on the fact that I'm going to win that lottery in New Berlin, which somebody won in New Berlin, and then I'm building it on just a hope, and then if somebody pulls the rug out, now we're in a world of hurt because we have an entire state budget built on this model.
Okay, Representative Riemer, where do you and Assembly Democrats stand on the governor's Medicaid expansion proposal? Why don't you lay that out for us?
Sure. And first of all, thank you for hosting this. Thanks to the Medical College for convening us in this space. Thanks to my colleague, Rep. Sanfelippo, for debating me. The question posed to us simply is Medicaid expansion right for Wisconsin? Yes, is both the answer that I would provide and the Assembly Democrats would provide. The first reason that I and I think most of my colleagues, Democratic colleagues, hopefully increasingly Republican colleagues as well, as we have this discussion and debate, will come to a similar conclusion, is that it does provide additional coverage, first and foremost for the most recent number I had was 82,000 individuals who, to my understanding, do not currently have coverage. Representative Sanfelippo indicated that some folks might have coverage who end up on Medicaid. I hadn't seen that. I think it's worth looking into, and certainly a legitimate concern or question to answer. I think sometimes we tend to take for granted that just getting more folks access to insurance is good, in its own right. To some extent, I feel that way. But there's pretty strong evidence that getting access to insurance has positive health outcomes associated with it and reduces the financial strain on families who go from lacking insurance to having insurance. There was a study in Oregon, which I think began in 2008, where they did random assignments of individuals to get onto their Medicaid program, partly because they had limited resources, I believe, to increase enrollment, partly to help understand what the effects were. They found a decrease in certain mental health problems like depression went down when folks got access to insurance, and financial stability for folks who had access to insurance through Medicaid increased. So in a word, helping cover more people, reducing their financial instability, and improving their health. The second point is the major savings that occur to the state of Wisconsin that open up the possibility to reinvest our tax dollars that we send to the federal government in supporting investments in healthcare, making people healthier in the state of Wisconsin. The most recent number that I have, and I missed most of Director Jones's presentation, is that the savings that the state generates in this budget through Medicaid expansion create $324 million of savings. That number goes up and down a little bit depending on how you tweak it, but I think the agreed upon number over the last three budget cycles, money that was missed because of not expanding Medicaid, was about just over $1.1 billion. Resources that could have been used to invest in infrastructure, invest in education, invest in health, invest in tax relief, certainly the kind of debate that Representative Sanfelippo, myself, and our 130 other colleagues would have a debate about how to use those resources, but generating those savings will, in the current budget that Governor Evers has proposed, create the opportunity to invest in things like, I just got a brief version of the list, extending coverage for women who've just given birth. Currently, Medicaid covers those women up to 300% of the federal poverty line for 60 days. This extends that to a year. Near and dear to my heart, we've got an 8-month-old baby at home, and my wife, who works at the medical college, is here as well. And
Oh, she can't ask a question then.
yeah, she's not allowed. It'll be too tough for me to answer. But just, from a personal standpoint, I'm sure others have similar experiences. I've spent more time at the doctor in the last 12 months associated with this birth and this baby than I have my whole life. So just a very important time in life. Evidence shows that that's important. Additional opportunities to make investments in making prescription drugs more affordable, improving wages for folks who provide long-term care, investments in access to dental service. Again,
Right, Jim went through
we did
those.
cover a lot of these. Okay.
Yeah, so let me just ask this question, because, the Republican, and I'll summarize here for this, Representative Sanfelippo, it's like, this is a budget buster, and you can't depend upon the feds to always give the money. And so you're setting all these new Medicaid recipients perhaps up to fail. How do you address that? Because after all, this is part of the budget, and so I think that has been what the Republicans have said here since the federal expansion money was available.
I think it's a fair criticism. I think it's one that could be applied to a number of federal programs that come to the state of Wisconsin. I think part of the discussion could include opportunities to sunset coverage for folks. That's not the ideal way to do it, but if it's a way to get support for Medicaid expansion, to say in the legislation, if the matching rate changes or changes beyond some of the expectations that we have, or changes in a way that leads to fiscal instability, and you can draw it up in a number of different ways, then we initiate a way to reduce eligibility. Again, I don't think that's ideal. It wouldn't be my preferred solution, but could be a way to get Republicans and Democrats to talk to each other about addressing a concern that I think is a legitimate one, not the way I'd address that I would address it in an ideal world. But I think if it gets Rep. Sanfelippo and others to the table to talk about ways to do this, I think it's worth discussing.
Okay, well, Representative Sanfelippo, is this a real point of discussion? Is there a possibility of compromise on this, or is it dead on arrival and you guys are starting all over again?
Well, I suspect, I'm not on joint finance, and Representative Riemer and I will tell you right now, the way the budgeting process works is we have very little say. The joint finance is very powerful. They do everything. I suspect what's going to happen is that they're going to go back to the base from the last budget, and whether that was the spending levels that were approved or the actual spend by agency, I think is yet to be determined. And the budget is going to be built from that level going forward. I think, again, there is areas where we can make agreement that things need to be done. I think the goal, the common goal here is the same, right? We want to get as much coverage to individuals as possible. It's just we have a little difference of who should be providing that coverage. We feel in the Republican caucus that it should be the private sector, which should go through private insurance. The Democrats want to do it through the Medicaid program. So that's really where the disconnect comes in. I think there are opportunities that exist now that were not there in the past as far as waivers in being able to perhaps take advantage of leveraging additional federal funds, but doing it in a way that is not going to greatly put a burden on our current Medicaid program that really bears some consideration for us looking forward to. And those are the areas I think where we ought to be able to work together to come up with some solutions.
So how much does the general health or vitality of the Affordable Care Act have to do with this? I mean, Jim Flaherty of AARP asked this before. It would seem to have, a great deal to do with it. But I guess I'd want to hear from you. How much does the ACA and the efforts to keep that going in Wisconsin, which Governor Walker initiated and Governor Evers is continuing, how much of that has to do with this and the success of this effort?
Is that a question for you or me?
Yeah.
Go ahead, Representative Marie. Or am I confusing it with my rambling question?
Okay, yeah, okay.
Well, I mean, much of the question would be, much of my answer would be trying to understand the Republican position on efforts to oppose the ACA, and I don't want to in the.
Well, there's a national Republican effort to kill the ACA, but Governor Walker had his proposal, and I believe Governor Evers is continuing it to help the ACA succeed in Wisconsin. Am I right about that?
Well, certainly the matching rates that provide 90% of the funding for new Medicaid recipients are built into the current law, which is one of the things I think is good and has been effective in the 36 states that have expanded Medicaid throughout the country. I suppose there are possibilities that the ACA could be repealed or changed drastically in a way that changes the matching rate in a way that does not generate the kinds of savings that could justify this. Currently, I think the $324 million in savings justify an idea I think is good on its own, which is helping people who don't have insurance get access to insurance. But, to reiterate an earlier point, federal laws change. The state often re-examines the things that we have on the books and state statute to try to adjust what we're doing based on what the feds have changed. That's pretty common, something that comes up pretty often in our committee work and as we vote on legislation and try to figure out how to handle those situations. If that could get Republicans to the table to have this discussion to say, if the ACA is repealed or some major portion of it with respect to the Medicaid expansion becomes null and void for whatever reason, whether it's the courts or something that Congress did, then we will change what we're doing in state law. In fact, the first bill that we worked on in the Health Committee this year specifically addressed in the legislation, if the ACA protections for people with pre-existing conditions are undone, then the state law kicks in to provide protections for people with pre-existing conditions. So not only can it be done theoretically, it's the first bill that Chairman Sanfelippo brought up in the Health Committee we both serve on. I voted for it on the floor. Didn't think it was perfect, but I thought, yeah, that's a way to address that very issue. What happens if the ACA or a piece of the ACA goes away? We can write it into state law and use state law to deal with that problem.
So Chairman Sanfelippo, you're hinting that there's more in common than we might think at the beginning of the debate.
Yes, and on the going back to the cost question, right? I think the bigger problem is not necessarily the ACA program itself; it's just the overall federal deficit, right? At $21 trillion right now, the federal government is struggling to cover the bills that it has to pay. If we go through another downturn like we've seen back in 07, 08, 09, we're going to be in a world of hurt. And if we think back to then, the government had their, I think it was called sequestration. They had this crazy word where they just went to a lot of agencies and just off the top lobbed off a certain percentage of their spending. I think if you see areas or things like that happening, and we are seeing a slowing in the economy around the world, I'm not saying it's going to get that drastic, but at that point, you could see the federal government starting to ratchet back those payments, right? So right now it's 90%. Maybe they go to 85, maybe they go to 80. But every bit that they take away goes more onto the state tax bill. That's why I think that it's very important going forward. We have to be very cautious with what we do so that we're not setting up a potential disaster to happen where we have this big commitment that we can't keep up with.
Okay, let's go to, you have something to add?
I was just going to say, going forward, I really think there are a lot of areas that we are in agreement on that we could work together, and Dan just mentioned one of them with pre-existing conditions. I mean, we have to admit, whether we like the overall Affordable Care Act or not, it has brought some very positive changes to the landscape. Many individuals are receiving coverage that didn't have coverage before, and many individuals or many different services are covered now that weren't covered before. But that has come with a price, right? And it's cost a lot of money. It's put a burden onto the system. I have never had an individual tell me, I want to be on Badger Care. I have a lot of people tell me, I want affordable health care. I want affordable coverage. I want better access to my doctors, but nobody has ever come to me and say, I want to be on Badger Care. So moving forward, our goal should be focusing on the 35 or 40,000 individuals who are not covered right now to figure out why aren't they covered and get them coverage. I believe it's best that we do that through the private sector. If you're a healthcare provider, I think you would rather see that done through the private sector as well. You would rather be reimbursed at a commercial rate than a Medicaid rate. I think for the overall health of the system, I think for the people in it, it's better for them to have some control over the program and being on these exchanges. Now, the Affordable Care Act was sold to us as that it has to be passed because people can't afford health insurance, and that we were going to wrap all these individuals in, young and old, healthy and unhealthy, to help kind of level out the cost for everybody. One of the biggest arguments we hear against doing options like limited term plans and things is we can't take people out of the pool because that's going to mess with the risk factor, which is going to deal with cost. Now we're talking about wholesale taking 40,000 people out of the exchanges, throwing them into Medicaid. That's going to deal, same thing, those concerns are still there. You're dealing with that cost pool, and that's going to drive the cost for everybody else up even higher.
Okay, so what is this, the number 82,000 versus 40,000? Or am I just misunderstanding? Can you clarify, because
Sure.
Jim Jones said 82,000 would be covered under Medicaid expansion, and you're using a 40,000 number.
The Fiscal Bureau had, and the DHS has given us a number that it would be 76,000 overall people under the governor's plan that would be shifted onto Medicaid. The governor's budget uses the number of 82,000. So, I mean, you know, relatively within the same amount. But half of the individuals that are going to be shifted onto Medicaid are already insured through the exchanges at this point. So DHS tells us that it's roughly a 50-50 split. Half are coming from are uninsured right now. Half are already receiving insurance in the exchange. Those would be shifted over onto Medicaid. So that's where you get that 75 to 80,000 number.
Okay, so let's go to the audience with some questions for our panel. Raise your hand and give me a couple minutes to get over there. Yeah, I'm going to disturb your lunch. All right, you get 2 questions today. That's good.
Sorry, I'm a chatty Kathy. So my question is regarding those people you're saying to be shifted. I just don't know. I don't have an intimate understanding of how Medicaid enrollment happens. So are you saying that they would automatically, without choice, be moved to the federal Medicaid system, or that they would have the option to be moved? I'm just unsure, because if nobody wants to be on Badgecare, I'm not sure if they would choose to forego their private sector option and switch to Medicaid.
So what happens is, right now we cover up to 100% FPL. Under the governor's proposal, we go to 138. So those individuals from the 100 to 138 that are in the exchanges right now, they're not forced onto Medicare, but they have the opportunity to shift. But what happens is they lose their subsidies from the federal government, right? If you're eligible for Medicaid, you can't get the federal subsidies, both for the premium subsidies as well as the out-of-pocket costs. So by nature, you're forcing those people, while you're technically not telling them you have no choice, they do have an option. They could stay in the exchange, but once you take away all those subsidies, they could no longer afford to stay in the exchange. So by de facto, you're forcing them onto Medicaid, and that's where that shift comes.
Representative Riemer, you want to add anything? You can jump in at any time.
I just hadn't seen the numbers that Representative Sanfelippo has referred to. It was my understanding that the 82,000 individuals were people who did not have coverage that would be receiving coverage for the first time through Medicaid. It's something we can look up, but in either case represents tens of thousands of individuals who do not have health insurance getting access to it. And maybe I just want to jump in here to say that I don't think the Republican versus Democratic position on this is getting people access to health insurance through the private sector versus government. I can't speak for all of my Democratic colleagues, but the goal is that people have good jobs, get access to good health insurance through their work by and large. Obviously, that can't be the case for every individual in the state of Wisconsin. Some people are truly unable to work because of a disability or because of old age. But in the event that people truly cannot afford health insurance and are not getting access to health care that they need, the government has some role to play. And figuring out whether government plays the role by expanding Medicaid or helping people get access to private insurance through exchanges or something else, I think is worth debating. But too many people don't have health insurance at the moment to just write it off as a let the market solve the problem type of conclusion.
Hi, Rachel Ruler with Advocate Aurora Healthcare. Thank you so much for being here today. One thing that the governor's budget has definitely shed a lot of light on are health disparities that he's looking to address, whether it's oral health or behavioral health. Infant mortality is another issue that's specifically critical in the community that we're in right now. I'm curious of those topics, where you think that there might be interest in mutually beneficial commonality between both parties, that regardless of this debate over healthcare financing, that we might see some movement on this session.
So I think that there are disparities, right? And over the course of the last 5-10 years, an effort has been made to gather the information to determine exactly where those disparities are, and kind of like the term right now I think is hotspotting with the young people who are into technology, right? And you find out where you have these little problems and little pockets of issues, and then you go ahead and deal with them. There definitely are in our urban areas, we see much different health situations than we see in the suburban communities, and in the rural areas, they face them alone. So I think the first thing we have to do is continue to work, and WHA has been a great partner with that in gathering this information, identifying where those problems are, and then focusing our resources into those areas. Because what's needed in my district is not necessarily what's needed in somebody's district who has a completely different population. And we know that coming from the socio and economic environment that you come from has a lot to do with your health. So going forward, we need to pay attention to those outcomes and focus on them. And that's one of the nice things that the governor does do in his budget. Unfortunately, it's built with money that I think is not there, but he adds significantly to the dish payments, and then he increases the maximum on the dish payments, because we have some of our hospitals, St. Joe's, for example, in the city of Milwaukee, a tremendous facility, but they're losing so much money because the vast majority of their folks there are Medicaid patients, and so they're just not getting enough reimbursement. Sinai is going to be another one, and St. Luke's is right on the heels. And so, we have to be paying attention to that problem and be able to address it going forward. And the way we keep people out of the expensive emergency rooms is to deal with the health situations right at the local level.
I'm thinking of a way to detach your question from the debate about Medicaid expansion and the additional resources that come in through the savings. I think there are a lot of shared objectives about some of the things that Rep. Sanfelippo discussed. We could talk additionally about drug treatment, addressing opioid heroin deaths and hospitalizations. Water quality was another issue where I think there is a growing bipartisan sense that this needs to be addressed in a way that responds to both the immediate needs of young kids who've basically been poisoned because of bad water, and the public health side of it, which has to do with infrastructure. Just two things I know are you didn't mention, but I don't disagree with what you mentioned. The point, I think, is with scarce resources, it becomes difficult to pursue as many objectives. Again, part of the main argument for Medicaid expansion is that we cover more people, but that we save the state just so much to reinvest in the health and well-being of the citizens here. And that's harder to do if you don't go in that direction.
Yeah, just following up that, I guess I'm a little confused on how we're going to get funds other than through the federal government through expanding Medicaid for these other services, especially if we're reticent to raise taxes. But also in terms of the payments to the states, I don't know that I've heard a lot of evidence about states not getting compensated for for expanding Medicaid. And in terms of thinking about it somewhat evenly in terms of how the private companies are providing insurance, they depend on payments from the government as well. And there have been, cases where they haven't been getting the money they're supposed to get. So I don't necessarily get the difference if, the coverage is being paid for by the federal government in some way, and we're so concerned about the federal government paying, what's the big difference between those two things?
So when the ACA first started, 23 cooperatives around the country were created to help provide, offer coverage, especially in areas where there weren't options, right? That number has dwindled to, I believe there's 4 of them left around the country, maybe 3. And it is mainly because they all lost boatloads of money through the ACA. And when you talk to, one of the few remaining co-ops is right here in our area, Common Ground Health Cooperative. And they actually have done a great job and run a great organization over there. And they're a nonprofit, but they will tell you that the government has drastically underpaid them on the commitments they made. And they're not just Common Ground, everybody. There are these things called risk corridor payments, right? And they're risk sharing payments. So the higher your losses were, the federal government was supposed to come in and give you a certain percentage of that. And people were getting, or organizations were getting, about 10 cents on the dollar from what the federal government owed them. So Common Ground, for example, if they were owed $50 million, they may have gotten a $4 million payment from the government. So that's a big hole to make up. Now, if the government has done that to these co-ops, put these co-ops out of business, if the government runs into money trouble, it's only a matter of time before they're going to start ratcheting down that 90%. And again, I say we only need to look at history. At the Medicaid reimbursement rates today coming from the federal government, that match has shrunk from what it used to be years ago, and there's no reason to believe going forward that it wouldn't be able to happen under the ACA program as well.
I mean, the state currently takes 60% funding for Medicaid recipients now. I mean, the idea is to readjust the way we're doing it to create the 90% match. I mean, 30 to 40%, depending on how the state budget gets drawn up, comes from the federal government. There's a risk, whether it's for infrastructure, health services, or other pieces that the feds either provide a matching rate or provide grants to the state for, that it could go away. That's a real concern. But it's as real for Medicaid as it is for anything else, as far as I can tell. I've heard this argument from Republicans, and I've yet to see how it's specific to this piece of Medicaid expansion. You know, and I think in some ways we're not even debating about whether or not to do Medicaid expansion, and we're sort of debating what kind of Medicaid expansion to do. When I first started, actually both Rep. Sanfelippo and I started in 2013, the budget did expand eligibility for Medicaid for some folks. It contracted it for other folks. So Governor Walker and to my knowledge, most of the Republicans then in the legislature voted for a kind of Medicaid expansion. It just was one that didn't provide the matching rate that allowed the state to save money. To my knowledge, specific to this expansion of Medicaid for other states, that the 36 states plus DC that have done it or are in the process of putting it together, that has not been something that has been a problem, with the exception of Montana. And I don't know all the details, but I think they put a referendum in place that said, we're having some trouble with the fiscal stability of this way of doing it. The referendum to the public had to do with, I think, an increase in fees on tobacco to shore up the program. As I understand it, it was rejected by the voters, and the government said, okay, we're moving in a different direction. That's not how I think we should do it in Wisconsin. I think there are ways to avoid doing that, but if it were a way to get Republicans to look at the kind of Medicaid expansion I think we should do versus the kind of Medicaid expansion that they did 6 years ago, then so be it. Let's discuss how we can create some safety valves, some ways to get out of it if it creates a major problem for our state's finances.
Okay,
Good question. Thank you.
question over here.
So I have a question for each person, and question for State Representative Riemer is, we do treat the uninsured at, Ascension St. Joe's and Aurora Sinai. We treat the uninsured, and our health centers treat the uninsured. And so the Medicaid expansion gives what's the argument that the Medicaid expansion just gives a little bit more money to those providers who already treat the uninsured? And if you expand Medicaid, then it helps those people who make less than $30,000 a year, but those who make 50, 60,000, they don't. How do they benefit? Do they benefit from the Medicaid expansion? And one way they would, instead of providing better benefits on opioid abuse, you would better fund these health centers who treat not just the uninsured, not just Medicaid, but those who make between 100% and 400% of salary and on a sliding scale. So that's my question to you: is how people who are not on Medicaid benefit from Medicaid expansion? And then for State Representative.
And then we'll go. And then you can ask.
Yeah, I was trying to take enough notes to quickly do that, and I knew if you asked Rep. Sanfelippo something, I'd forget your questions, which are very good. The first question was about additional resources going to the providers who provide uncompensated care, and how it shores up their ability to do that. To my knowledge, the studies I've seen and the summaries of studies across the country indicate that that's the case. The Oregon study, which I referred to earlier, I thought said something like 60 cents of each extra dollar was going to those providers. There may have been a qualification there, and I read a summary of it in The Economist. I haven't read the full study, full disclosure, just some of the abstracts and other pieces of it that have described it. Summaries of lots of the studies that have been done that have looked at that issue, to my knowledge, indicate that those additional resources do go to providers, like the folks at St. Joe's, which is where I was born. So thanks for doing the work you do there to help those folks. But my sense is, and it seems to correspond to common sense, is that if people have insurance, even if it's not ideal, versus not having insurance, and they're going in for the same amount of care, will help providers and also help those individuals. There's some evidence that folks seek more care once they get access to insurance. That leads to some questions about the overall cost. Are they actually getting more preventive services? Are they still using the ED to get treated? I've seen mixed evidence on that, and I think it's an issue to address if this is the case, along with some of the capacity issues that Rep. Sanfelippo brought up, which I think are legitimate and ought to be addressed in a way that makes sense for providers and also the patients. The second question was about, as I understand it, folks who are receiving coverage, maybe through the exchange, they're based on the income range you said, which I didn't have time to write down, not within the 100 to 138% range, but maybe lower.
But he was
lower.
saying if you're making 60 grand a year instead of 30 grand,
Right.
how's that helping you?
Right.
I think you have the power to help. You get this extra money. You have the power to help people who outside those who get Medicaid.
Right.
So I'm wondering if you've thought about that or not.
I hope my pitch for Medicaid expansion did not indicate that the sun would always be out and that everything was going to be solved by this issue. It was a way to. I hope I was as clear and detailed as possible about the things I think are the benefits of doing it, and I hope I was also realistic about some of the costs, some of which I agree with Representative Sanfelippo on, some of which I think he's mistaken about. But that's a good question. What to do about that? How to address folks who are receiving inadequate coverage through the exchanges or are dealing with other issues. And I don't know that we have enough time to get into that fully. But I'll maybe I'm around after.
Why don't you ponder that a little bit? Okay,
Just to tie it into this discussion, my pitch and others who are advocating for Medicaid expansion, I hope are not claiming inaccurately that it's going to solve all of the issues in our healthcare system, one of which you just brought up.
Okay, and now here's your question for Representative Sanfelippo.
So I apologize taking up so much time, but State Rep. Sanfelippo, so you mentioned that, so thank you for being here. You mentioned that, this should be government-run health insurance, Medicaid is, and I agree. However, the difference is you are part of the government, right? I mean, you're the state, because Medicaid is run by the state, and Medicare is run by the federal government, which I agree, you have no control over what happens in Washington. So, but if you did have a magic wand, which you almost do, you could create a Medicaid expansion program. Governor Evers can veto it, but why not, I guess, write up a Medicaid expansion proposal that could involve the private sector? Thanks.
So I think
Okay, so do you have a magic wand? Because if you do, that would be very helpful.
if I had a magic wand, I would have won that Powerball ticket yesterday at New Berlin. But I could have funded Medicaid, that's right. So I think going forward, you're going to see the Republican caucus come out with some options to be able to leverage some additional federal dollars. Because as Dan mentioned, we did do a Medicaid expansion here in Wisconsin. We did a very significant one. We just didn't use federal dollars in order to do it for a variety of reasons. But I think you'll definitely see some options and proposals coming out from the Republican caucus that will leverage additional federal dollars, but use them in a way so that we're not expanding Medicaid the government-run program, but we're doing it in a way where we're building people up so that they can get into the private sector. One of the things Director Jones brought up was this cliff, right? And it's a huge deterrent to people in the workforce who won't take a pay increase or work overtime or take a job promotion because all of a sudden, boom, they're dropped off this Medicaid cliff. So I think we could take these dollars, leverage them in a way where we smooth out that cliff so people aren't getting punished for actually succeeding in life and be able to go beyond, as you mentioned before, beyond subsidizing the folks from 100% or up to 138%, but get more into that 200, 300, 400 percentile group where in addition to them getting their federal subsidies, now maybe we have a state subsidy as well to lower that out-of-pocket cost and make those folks on the bottom rung of the ladder having their coverage much more affordable, but the key being private sector coverage.
Okay, so I want to thank you, the audience. Want to thank Representative Riemer and Chairman Sanfelippo and Director Jones before. Want to thank our sponsors, of course, the Medical College of Wisconsin and all the staff help we had in putting this together. UW-Milwaukee, 1125 at Pabst, Waggett, Spectrum, and the Firm Consulting and the Milwaukee Police Association. So thank you all very much, and give them a round of applause.